30 years ago, I had darker hair and more hair, and a much poorer understanding of aortic outcomes for various conditions. We thought everybody that was tall and thin and had skeletal features, of course, had Marfan syndrome. And in our clinic, that started as a Marfan clinic in 1992, has become much more because of the understanding of the genes that I'm going to talk about today. We started collecting consecutive patients who we found rare heritable thoracic disease genes in 2015 in a consecutive database, now up to about 620 patients over the last 8 years. And you can see now in our clinic, the newer patients we're seeing are actually non-Marfan, more than Marfan. So about 340 with Marfan, half that with Loeys-Dietz, a tenth the number of VEDs compared to Marfan, similar to the population estimations that we have, and then the other genes that are recognized. In Marfan syndrome, it's well recognized, and from work from our speakers and our honored guests today, an aortic root diameter of about 5 centimeters is the benchmark for preventative surgery. And this is one of the landmark papers identifying the low risk on aortas under surveillance between 45 and 49 millimeters. Two events out of 157 patients in that data set, or a 0.3% annual risk. But just like in all series, a fifth of patients under that same size range did have prophylactic surgery under watch for various reasons, whether that be pregnancy, mitral surgery, valve disease, or some under indication. And again, as Guillaume presented the information there, the risk of an event is really pretty low. It's just not zero when you're under watch, and that's something we talk to patients so they're educated and can advocate for themselves. And we're seeing probably just as many type Bs in our young people that were under observation that we don't have good understanding or prediction. This is the data plot from that paper that I found really interesting. So this is aortic root size, and the line is 50, and there's a couple events more than 50. And between 45 and 50, of course, there's many more patients, but again, a couple events. So 16 patients being observed over the 2 years of 50 or more, and of course, 2 out of 16 had dissection, so that's a high-risk group. But of the 40 patients that were in the group between 45 and 49, 2 out of 40 or 5% did experience an aortic dissection. So it can occur in smaller aortas. And when we look at this, a provocative paper asking the same sort of question, should we anticipate earlier surgery for some? Again, small risk at 40 to 44, almost zero. It's a little bit higher from 45 to 49, and a much higher risk at 50. And it is pretty interesting how similar the two papers are as far as the numbers. There are 43 patients with an aorta of more than 50 and 9% event rate. And of the 66, between 45 and 49, almost identical, 4.5% aortic risk. So in the guidelines that were just published, 50 millimeters is a benchmark for preventive surgery, and greater than 45 for special circumstances, especially before pregnancy, etc. And I think one of the highlights of the guidelines, again, is emphasizing what surgeons do now compared to 30 years ago, is to resect the entirety of the ascending aorta, not just the root, but all the way up, because that prevents late aortic events involving the ascending aorta, certainly something we see now more in people operated on in the earlier eras. And then in people who have Marfan that are approaching surgical thresholds, so right on the cusp there that want to have surgery that are at very low risk, I think it's reasonable to consider that when done by an outstanding surgeon. The guidelines to make the diagnosis of Marfan syndrome are certainly not perfect. In number 3 there, an aortic diameter of dilated and a high systemic score can define Marfan syndrome. Now, of course, there's a lot of overlap, so it's emphasized in this paper, no features of a related heritable thoracic condition, in particular the Loeys-Dietz family. In 2005, when we were invited to go to Hopkins to learn about the trial and participate in the trial, one of the trials of losartan and atenolol in the Pediatric Heart Network, Bart reported this series before publication and educated us about the 14 patients in 10 families that later became known as Loeys-Dietz syndrome due to mutations in TGFBR1 and 2. And after returning home from that meeting, I saw this lady in the office, that I thought had Marfan syndrome, that we had diagnosed with Marfan syndrome years before, and she dissected her aorta at 3.9 centimeters. It always really bothered me why that would happen away from pregnancy without hypertension and no risk, just under watch, being advised that that was okay to watch. And of course, she had, I'd never looked at her mouth before as a clinical cardiologist, but she had had cleft palate surgery and a bifid uvula, abnormal enamel of her teeth. She had marked arterial tortuosity, and this was one of the earlier cases of TGFBR2 variant. And she had a severe phenotype, which again would help predict, as we know now, her earlier onset aortic disease. So the guidelines emphasize the differences in Loeys-Dietz with a characteristic phenotype that should be recognized now that can be quite variable. So we look for more severe phenotype in the craniofacial and the arterial tortuosity to inform aortic disease risk. And those sort of features have gone into the guidelines. So we screen more widely, we image more widely, and it's not only to identify whether problems are present, but whether they inform surgical risk. Interesting that the Marfan patients you described have higher cutaneous feature might predict some aortic outcomes. That's the same as in Loeys-Dietz syndrome with visible veins, translucent skin. We described a whole series of patients that had this facial milia pattern in Loeys-Dietz syndrome. In the first paper, the large paper of 90 patients in 52 families with TGFBR2 and TGFBR1 mutations published by Bart and Howe with the multiple co-authors is listed. Even in the earliest information from this paper, you can see that there was granular information available about differences in outcomes. And of course, this was a series overrepresented by young people with the most severe phenotypes. Of course, that's how they were recognized. But even in this group, there was a strong correlation between the severity, the presence and severity of the craniofacial features, hypertelorism, craniosynostosis, bifid uvula, cleft palate, and aortic outcomes with a 10-year earlier onset of morbid events in this group in the most severe phenotypes. In this population of very aggressive Loeys-Dietz syndrome, you can see that by age 40, half the patients had died. And again, the most severe clinical outcomes were in those with the most severe craniofacial indices. So that basic early experience defined the recommendations from this paper, saying that aortic dilation of a z-score of 3 or so would indicate surgery. That was the earliest information from this data set, and again, based on 2 adults with very early onset dissections, and they recommended in this paper a 4-centimeter benchmark for replacement in people severely affected in young adulthood, informed by personal assessment, risks, benefits, etc. The 2010 guidelines used the numbers of 4.2 centimeters by TEE and about 4.5 by CT or MR to recommend the benchmark for prophylactic surgery with a class 2A indication given. And the Montalcino Aortic Consortium provide a lot of very important information from later onset, or adults in particular, with a much larger data set with more relatives of probands involved as well. So you can see 441 patients with TGFBR1 and 2 variants, 23% with dissections, about 20% had preventive surgery. And differing from panel A on the right from the Loeys paper with earlier onset mortality, the survival was 80% at 60 years. Again, probably a combination of earlier recognition, screening of family members, better understanding of the condition itself, and a different subset in some individuals than the earliest onset aggressive childhood disease. But still, in this large group, 50% of individuals with TGFBR1 and 2 had either dissection or preventive aortic surgery by age 40 years old. So again, aggressive disease. And looking at this paper from Guillain, John Doe, and colleagues, looking at the MAC data set, the red squares indicate females with aortic dissection and a TGFBR2 mutation, and there were 6 individuals with this characteristic that had dissections at small aortic size. So there is more prediction, and there is more granularity, and genotype does matter as well as other features. In this paper, multivariable analysis of 3 other phenotypic features, hypertelorism, tortuous aorta, and widened scars, again, other phenotypic features that are identifiable, did have an increased odds ratio to predict aortic events. There's much less information available for some of the other genes that can lead to a phenotype that overlaps Loeys-Dietz syndrome, SMAD3-related osteoarthritis, aneurysm syndrome. Aortic diameter at the time of dissection in the literature is reported between 4 and 6.6 centimeters. Fewer case series of TGFB2-related Loeys-Dietz syndrome or heritable thoracic disease. And again, aortic disease risk looks to be lesser than those due to the other variants, and very few cases of dissection reported in the literature for these genotypes, one less than 5 centimeters, and prophylactic surgery reported between 4.5 and 5.4. And we reported data from the Montalcino Aortic Consortium at the last ACC meeting of TGFB3-related heritable thoracic disease. There were only 2 type A dissections. One had information, 4.7 centimeters, and 5 individuals, importantly, under watch between 4.3 and 4.9 centimeters without any aortic events. Diana talked about this already, so I'm going to skip these 2 slides and just go right to the information from the AHA guidelines, that in patients who have heritable thoracic disease due to one of these genes, or any of the genes that associate with heritable thoracic aneurysm, surgical thresholds are informed by the genotype and then other personalization based upon their individual features. And then for people with Loeys-Dietz syndrome, to one of the 5 genes that we mentioned, the variant, the diameter, the growth rate, the presence and severity of extra-aortic features, the family history, patient age, sex, and then physician, patient preferences, and surgical expertise all go into the guidelines that Diana showed before, and I appreciate her help with working on this important section of the guidelines. It's invaluable, outlining the classes of recommendations, the differences in genes, the presence or absence of high-risk features in the various aortic diameters, with the bottom line being a shared decision-making when the aorta is dilated in an individual with one of these conditions. So in summary, the timing of surgery is variable in Loeys-Dietz, caused by variants in the genes associating this TGF-beta signaling pathway. There are many factors that are involved. It's not the diameter alone. Again, we consider this for all of our individuals, and surgical expertise, patient and physician wishes, and a shared decision-making are very important. And I'll finish by just saying that in my institution, I have the honor of chairing a fellowship for aortopathy and master clinician that's certainly open worldwide, and we'd love to have a Spanish compatriot join us one time for a year-long fellowship. If interest, we'd have our 2nd fellow finishing her year now, and certainly open for applications. So thank you for your attention.